So enchondromas / Euler's disease. So if it's a solitary thing, we're going to call it an enchondroma. If we've got loads, we'll call it endochondrosis. It likes tubular bones of the hands, particularly the metaphyses of the long bones. Happens quite a lot in kids. These lesions are lucent, expansile, they're intramedullary, and you know, in the exam, we like these buzzwords. Everyone likes to feel good when we hear these words. So ring and arc matrix, endosteal scalloping, that's another key buzzword. So if you see lots of these lesions, you should have Maffucci syndrome somewhere in the back of your mind, and you can look around for phlebolysis or soft tissue calcification, and that will tell you, or that may alert you to the presence of multiple soft tissue hemangiomas around these lesions, more often than not on the hands. And there is a tiniest chance of chondrosarcomatous transformation. So as I said, lucent, expansile, rings and arcs. So here we go. Here's a lesion here affecting this second ray. So this one's really beautifully intramedullary based. It's expanded, and you've got some endosteal scalloping. The rings and arcs are probably better depicted on this one here. This one's a little bit exophytic. So these will do very nicely for enchondromas. Very nicely for enchondromas. So this is a DP view, as in dorsal palmar view. And then this is an oblique view. So very nice expansile lucent lesions. So if you've not seen them before, burn this one in your brain. These are enchondromas. And this one has just gone crazy, hey? There are loads and loads and loads of them. So this is on the left hand, this is on the right hand, multiple expansile lucent lytic lesions. So these are just different examples of what these enchondromas will look like. I didn't have one in my library that has got lots of phlebolysis with Maffucci's, but you know, that's what Google's for. Hopefully that makes sense. Feel free to just continue chatting if there are things that are unfamiliar or that you would like me to clarify. I'm just gonna have a sip. Now this one, I'm not gonna see every day. Less likely to see unless you work in a children's centre, but you know, they might just throw it in. Yeah, indeed. I tell you, Ahmed is on fire. So there absolutely is a pseudoarthrosis. This is a very rare thing, but then once you've seen it, then you kind of never forget it. So you get proliferation of fibroosseous tissue. It happens in younger kids. It loves the leg, as in the anatomical leg, rather than the thigh or the forearm. It just loves to go here. You get bowing, and this is the pseudoarthrosis that Ahmed was highlighting to us. So this is kind of pathognomonic, actually. When you see it, please do refer to orthopedics. So this is another flavor of lucent expansile lesions. But when you see it in the leg rather than the small bones of the hand, and particularly when you pick up the pseudoarthrosis, then it's almost certainly going to be this thing, osteofibrous dysplasia. From our point of view, pediatric orthopedics, then they can worry about the corrective surgery and how it affects their gait and development. Osteofibrous dysplasia, pediatric orthopedics, look out for the pseudoarthrosis. Chat. Yes, so is in the differential, yes. Oh, I assume you mean osteogenesis imperfecta. Yes, in a sense that you can get pseudoarthrosis from multiple fractures where they are trying to heal, but they don't quite heal very nicely. However, with osteogenesis imperfecta, you tend not to get this quite marked expansion of the bone. You tend not to get the expansion of the bone. And also, this tends to affect only one limb. Although osteogenesis imperfecta can affect only one limb, it would more often than not, in fact, I realized I said that a lot today. I'll say it again. More often than not, affect multiple bones, whereas this one almost exclusively affects the anatomical leg. So yes, pseudoarthrosis, because you've got multiple fractures that are trying to heal, that would throw it in the differential, and I think that is a very reasonable thing to bring the bring to the table for the discussion. You tend not to get as much expansion, and it tends to be affecting the anatomical leg. NF1 doesn't really tend to give you the expansion either. Doesn't tend to give you the expansion either. The pseudoarthrosis, yes, I would definitely agree. It's one of the differentials for that, but not so much expansion. Fibrous dysplasia. Well, yes, I mean, this is basically a subtype of fibrous dysplasia because it's in the name. Yes, it's a subtype of fibrous dysplasia. It's a rare type that affects kids, and it likes to go to this particular part of the body. Whereas, as you know, with fibrous dysplasia, you can get them in the skull base, you can get them anywhere, isn't it? You can get them anywhere. Good seeing lots of engaged, hungry minds. I'm loving it. I'm loving it. So let's have a look at this one. You're welcome. Let's have a look at this one. So on the form, it's a query leg length discrepancy, and there absolutely is a leg length discrepancy. I wonder, yeah. See, you guys know this one. I won't spend too long on this one. Absolutely right. It is Blount. So we've got fragment. There's hopefully a magged up version if I remember to do it. Yeah. So we've got a varus deformity. It loves here, isn't it? It loves here the medial aspect of the proximal tibial metastasis. Orthopedics, they can do funky things with their epiphysiodesis. So in terms of the radiological findings, you get beaking, medial slanting, fragmentation, sclerosis as well. And this particular site is pathognomonic. Other thing I want to mention to you is that, so these are the primary findings here at the proximal tibial metaphysis. But let's not forget the epiphysis here, because this is a bit slanted as well compared to the normal lateral side. You do get downwards slanting on the medial aspect of the epiphysis. As for how this thing happens, to be honest, I haven't really had a very satisfactory explanation. It's something to do with the biomechanics on the medial aspect of the knee. But then, you know, why doesn't everyone get that? It's not AVN in its purest form either. So I can't really give you a 100% concrete explanation as to why this thing happens in some kids and not compared to others, mainly because I haven't found one that I've not really been entirely satisfied that really makes sense to me. But it's a thing, and it's to do with the biomechanics on the lower leg around the knee. So treatment-wise, it can be conservative if it's just a minor lesion. If they want to go down the surgical route, you would do epiphysiodesis. So what does that mean? That means iatrogenic premature closure of this growth plate here. Some more things. Ooh. Yes, Becky's feeding us some good stuff. Thank you, Becky, keeping us on our toes. Good, good. So I wanted to mention a few things about skeletal dysplasias now. And don't worry, don't start crying. I know they are tough. Even I struggle with them as well. And it is a minefield. There are literally hundreds, but I'm just going to give you just a few. Stay with me, stay with me, stay strong. You've got this. So this is a 2-year-old boy, and they have got one of the MPSs, so mucopolysaccharidoses. Yes, Ahmed. Yes, Ahmed. So what things can we pick up on here? They do tend to get skeletal surveys as well, but in a different way to the abuse skeletal surveys. With the skeletal surveys for abuse, you're going to do basically every bone. Whereas with a skeletal survey for a dysplasia, you're going to do the spine and the pelvis and one side of the body, because the findings are going to be symmetrical. So you don't need to do every single bone. So you can spare them some dose. So what's particularly interesting, this is a Hickman line as well, if you haven't seen one of these, by the way. This is a double lumen Hickman line because they can be treated with bone marrow transplants. What's interesting on this one here is that you have got narrowing of the intercostal spaces. Why is that? Because these posterior ribs are very, very chunky. They are widened, and this can be one of the features of an MPS. This is a beautiful spinal X-ray. I mean, to be honest, I could look at this thing all day long. Oh, what's on the chat? Yeah. I'll come back to that one. In fact, I'll just quickly mention that one now, Mahek. For the purpose of this, just because I'm very conscious of time, just go for pediatric orthopedic referral to manage the osteofibrous dysplasia. They'll know what to do. There are conservative and there are surgical treatment strategies. But if you say pediatric orthopedics, that will do for now, I think. This is it's a thing of beauty. In fact, shall we let's take a minute and see how beautiful this thing is. I mean, it's lovely. So this is a very hypoplastic L1 vertebral body. So this is a cone down view of the lumbar spine. So it's a bit small here compared to its friends T12. And also there is some anterior beaking. And if you look at the alignment here, there is what we call a gibbous deformity, which is an exaggerated kyphosis, which is centered around L1. So that's something that we can pick up with MPSs. There's a question for you on the screen. I'll tell you, this one is not MPS, but I put it in here because it is a skeletal dysplasia and there are some overlapping features. I'll just give it another 5 seconds to soak in so we can appreciate the beauty of these images that's on the screen. A few suggestions, all up to 5. Okay, I can't wait any longer. High fives all round. You guys are just, so, you know what? You don't even need me. You don't even need me. You're on it. You're on it. Very good, very good, very good. So the reason why I've just thrown a sneaky achondroplasia into the mix is because I want us to be able to appreciate some of the similarities and the differences in the spinal appearances between achondroplasia, which is clearly a skeletal dysplasia, and Hunter-Hurder's, which is one of the MPSs, which is the skeletal dysplasia, but is not the same. It looks a bit different. The prognosis is different. The treatment is different. You don't give achondroplasia patients a bone marrow transplant. Similar but not the same. Similar but not the same. So why is that important? So this one here is the achondroplasia. This one here is the achondroplasia. This one is particularly beautiful. Why? Because we've got some posterior scalloping. Let's look here. This is a good one. Look, scalloped, 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 scallops. And if anyone's feeling particularly brave, maybe you can throw in some differentials of posterior and vertebral scalloping as a broader thing. So where they overlap is that we've got a gibbous deformity here, centered around L1, centered around L1. But there are some key differences here. We do not have any posterior scalloping here. So let's take this one and let's take this one. Look, no scalloping. So that's the difference. Let's go back to the similarities. Similarities, we have got some beaking, but where is the beaking? This one here with the Hunter-Hurder's, classically, and I know it's a bit tricky, please stay with me. Classically, they say it's beaking of the inferior vertebral body, so it's lower down. It's lower down here. With achondroplasia, I know it's tricky. I know it's tricky. They say the beaking happens in the middle third. I know, bear with me. But these are some of the classic differences. And I know it's tricky. And even for those of us who look at them most days of the week, it is tricky. But these are some of the similarities and differences. I think the posterior scalloping is probably the most conspicuous and striking difference, as in it's present in achondroplasia, it's not present in Hunter-Hurder's. See, this is nice and ovoid. And where the beaking is inferiorly Hunter-Hurder's and the middle third in achondroplasia. Ooh. This stuff is just so tasty. Yes, duolectosia. Yes, to NF. Yes, acromegaly, and yes, spinal tumors. Yeah, particularly ependymomas. They love that. Duolectasia and F. Yes, yes. Just you guys give me joy right now. So please keep up the energy. I'm really enjoying it, guys. So some of the things. Have a look. We've got 12 minutes. See what we can do, see what we can do. Becky's gonna cut me off soon. Aggressive bone lesions. So all the stuff that we've done before, I tried to give you some of the characteristic findings, and I think I've tried to be quite careful in selecting images that don't have aggressive features, i.e. narrow zone of transition, or in fact, the fractures had aggressive features, apart from the fractures in the eye. Narrow zone of transition, relatively well-defined, all those things. But there are things that have aggressive features, and I need to open the floor with a question. Here is the history. Oh, wait, let me see what's said beforehand. Oh, my video is paused. Oh, I don't know. I didn't do anything on my side. Yes, you can get central beacon with Morchio as well. That is true. See, it's hard. It's true. That is true. I'm not sure how the pausing came on. I'm not sure. I've not done anything on my side. So, hit me. I think we can get to at least 5. This is an abnormal and aggressive bony lesion. This particular one is in a flat bone of a kid who presented with hip pain. But you know what? Let's pretend it's not a flat bone. Let's pretend it's any bone. Aggressive lesions in the pediatric population. Go. Okay, let me see. Oh man, easy guys. You guys are you're on fire. Let me go back to the top. Okay. Ewing's, yes. A couple of Ewing's, yes. Aggressive lesion, yes. Ewing's, yeah, I love that. Neuroblastoma Mets, yep, that's 2. I'm taking that. Neuroblastoma, yeah, they got, yep, good. Yes. Ewing's couple of fusion, yeah, good. Lymphoma, osteomyelitis, yeah. 4, osteosarcoma, yes. As a general theme, yes. Osteomyelitis, yes. Good. Loving all of those. There, in fact, there's one missing, which it turned out to be in this particular case. And I love this case because hardly anyone gets it. Oh, one more chat. Oh. You guys beat me to it. Yes, LCH. You got me. Can't catch you out. You're too good. So as we know, there are some lesions that favor flat bones, and we're going to talk about that. And there are some lesions that favor tubular bones, and we're going to talk about that. So this one did turn out to be Langerhan cell histiocytosis. So why is this aggressive, by the way? Why is this aggressive? Because we've got a wide zone of transition. It's very ill-defined. It doesn't quite look right, does it? It's very permeative. And actually, I didn't have time to build the lecture enough to give you the MRI, but there was a massive soft tissue component to this one as well, which ended up being the target of biopsy, which confirmed the diagnosis. So this turned out to be LCH. So we said that. Yeah, we got all the ones that we had in mind. There are a couple more, but let's not go too crazy. There's always exceptions to the rule, but these are the ones I want to kind of burn in your brain for sure. So LCH, but this is a bit small. Sorry that the writing's a bit small. So it's a lytic lesion. Yeah, usually the child is well. Having said that, not exclusively, and we're going to talk about symptoms in a minute, they do have variable degrees of aggressiveness. LCH does like flat bones, so does Ewing's, which is probably why it was one of the top differentials correctly in the chat options. So very good for that. Permeative, non-geographical. They tend not to have a sclerotic margin. Perosteal reaction, yes, absolutely, in the advanced stage. So this is one of the options for aggressive bone lesions in children. Neuroblastoma. So neuroblastoma we see relatively common in terms of cancers in children. It's certainly the most common extracranial solid cancer in children. Classically, it does like to go to the adrenal gland, but not necessarily exclusively so the other places as well. The sympathetic chain, particularly in the chest, it runs in the paravertebral space. And if you've got an X-ray with widening of the posterior ribs, then sometimes you can have a neuroblastoma, which is affecting the sympathetic chain in the chest. So be aware of that. So that can go into the abdomen as well. And also randomly, but it's a thing. There's this thing called the organ of Zucker-Kandel, which is at the aortic bifurcation in the pelvis. Helps regulate blood pressure. So what you're going to see, calcification, neuroblastoma likes to encase. So this isn't primarily a cancer talk, but I just wanted to remind you of some of the features that we see in neuroblastoma. And on T2, if we're going to do an MRI, then they do look very heterogeneously, and they're bright. Now then, if you weren't aware, I'm just going to throw this in there just to update your knowledge. We used to talk about stages 1 to 4. That is dead, that is old, that we don't do that anymore. We talk about stages L1 to L4 and also MS. So why is that important? Because the staging system is now impacted by this new thing. Oh, I can't highlight it because I'm not on the other method. It's now framed around the International Neuroblastoma Risk Group. And what we have are these image-defined risk factors, And they're the things that are going to tell us the stage. So L1, L2, M, and MS. So actually, it's a bit easier. And there are about 30 or even 40 imaging-defined risk factors. So Google it if you've never heard of it. It's a thing. And how do we stage it? So this is where we're going to come back to our bony lesion topic for the day. So we do an MIBG scan, particularly looking for bony mets. So we're not doing an MIBG scan to stage the primary disease, because if you're thinking that you've got a mass in the abdomen, the best way to do that is to do an MRI of the abdomen with contrast and DWI and ADC to stage the primary mass. But MIBG is really good at looking for bony metastases. You just need to be aware that 10% of these bony lesions, again, bringing it back to the bone for us, are not MIBG avid, but they are FDG PET avid, okay? And you can do a chest X-ray plus or minus a chest CT, depending on where you work, if the original chest X-ray is abnormal. So this is a scan of the belly, a 3-year-old with a 4-week history of back pain. There is this blob in the belly. That's what this scan is supposed to demonstrate here. So this is the primary tumor, which is a retroperitoneal mass, which is encasing the aorta here, which demonstrates restricted diffusion. But again, bring it back to the bones. This is an MIBG study, and we've got all of these areas of avid uptake here. And in case you didn't know, an MIBG scan, the spine is supposed to be photopenic. The spine is supposed to be photopenic. So the fact that you've got all of this increased uptake in the spine tells you that this kid, unfortunately, has got really advanced florid bony metastases. This is what it looks like. So the primary mass is here. This is what it looks like on the SPECT CT, and with these areas of increased uptake here. I'll probably skip this one for the sake of time. That's more into the deep cancer talk. What do we think? One-word diagnosis. Still with me? 4-year-old short of breath. You got it first, you got it first, you got it first. I can't. Oh, interesting. CPAM. Interesting. Let me draw your attention to this bad boy just here. Expansile, progressive, reaction. Yeah. To be fair, neuroblastoma metastases has to be in there. Oh, PPB. Good skills, Oma. Good skills. I'm going to save that one. It's so good. I'm just going to save it for now. It's not for today because they tend not to present with aggressive bony lesions, but they can present with these very abnormal soft tissue lesions. So the reason why I showed you this is because all of this density in this right chest was actually related to an enormous soft tissue tumor, which originated from the bone. which originated from the bone. So this is actually the primary tumor. And all of this is the soft tissue component. So here we're thinking, so why is it not a pleural effusion? So why haven't, if it is a pleural effusion, why haven't you got something down here? It should fill from the bottom up, isn't it, if the child is sitting? So all of this stuff here is the soft tissue mass related to the primary lesion, which is the Askins tumor, or in other words, the Ewing's sarcoma. So here it is. So this is the soft tissue mass. Here it is on the lung windows. And here's the lesion. This is the bony bit here. And this is where the soft tissue bit has absolutely exploded. There is heterogeneous contrast enhancement, and there is also restricted diffusion as well. So, I mean, to be honest, this tumor is mind-blowing, but the crux, the key, the gold in this particular case here is picking up that there is an expansile, loose and aggressive looking bony lesion. And then hopefully the rest of it will kind of fall into place. Yeah, round cell tumor. Yeah, exactly. Good skills, guys. I could feel Becky knocking on my door because I'm kind of out of time.
That's okay.
Okay.
As long as you have time, we're good.
Okay, good. Good news, guys. I've been blessed with another 5 minutes. So we've got aggressive lesions with wide zone of transition, peristaltic reaction. The malignant side, osteosarcoma, as I said, it tends to like, not exclusively, it tends to like flat bones in older kids as well, in fact, into young adulthood as well. So these are the ones. So the reason why we like saying aggressive and non-aggressive rather than malignant and non-malignant is because you can get aggressive lesions that are not cancer. So this is the management there for your Ewing sarcoma.